This talk is a little bit unusual in that we're going to actually show the K12 data closer to the end because the foundational stuff is a little bit different than, I don't know, what I personally had been exposed to before. So I thought it was helpful to spend time on definitions. What we're doing right now is kind of at the intersection of doctor-patient communication and patient outcomes. Okay, so it is about quality outcomes. It is a reflection of quality of life and how interpretation of quality of life can impact clinical care. But it is it's an application of qualitative science and dissemination implementation science. So there's a lot of kind of like foundational stuff to talk about. We're in a really cool space that I'm excited about. And the reason I actually asked Alex to mention the fellowship that I did is I highly recommend everybody to apply for it. If you have the chance and you're interested in qualitative research, please let me know after this because I learned a lot from my 2 years with them. It was really formative. Okay. So my only disclosure, everybody here has the same disclosure. So it's
Do you
not that
want to put this
exciting.
in presentation mode, Vinaya?
Oh yeah, totally. Sorry. Is it working? Okay, cool.
That's good.
I don't even know why I didn't realize I hadn't done that. Okay, so why is this topic timely? This is a time in which, health literacy is impacting every aspect of how we interact with patients and provide care. But I would argue it also impacts how we plan out interventions and disseminate them, right? And so thinking about that in a systematic and somewhat rigorous fashion can help us also be better communicators with our patients and make sure that they learn from what we're doing in ways that are meaningful and impactful. Because if we make our information, the highest quality, most scientific information, more acceptable to people, they will listen, right? And I think that's what we're learning from, the sociopolitical climate that we're currently in. So I'm going to talk a little bit about how we measure several different forms of health literacy, things I did not know before this fellowship. There's more than one type of health literacy. There's actually many ways to measure health literacy, and then e-health literacy, which we'll talk about what that means, and then digital literacy. So a lot, a lot to cover here. And then how this impacts, care outcomes in chronic disease, also variable, and so opportunities to improve care paradigms may also be variable, but there's ways that we can look at these things at specific time points and respond to them that will improve how we conduct studies, deliver care, could even improve our outcomes, right? And prevent attrition from studies. So lots to cover here. Okay, so let's get to the super fun topic of 100 definitions. Okay, so the WHO came out with the idea of health literacy about 25 to 30 years ago. They said that health literacy is the ability to access, understand, appraise, and then use information to make healthy choices, right? And the CDC actually, I think, made a very important update to that, where they broke it down into personal health literacy. So that's like what a patient brings to clinic, and organizational health literacy. This is the part that we can impact. It's our job as the care team to impart health information in ways that are understandable and reproducible by our patients, right? So it's sort of our job. So what does health literacy depend on? There's an element of oral understanding, what we say to patients. There's an element of intrinsic health knowledge, what the patient comes to us already knowing about health or healthcare, and their ability to navigate health systems, right? So all of those kind of come into play here. So how can health literacy be measured? Well, there is a great tool from University of North Carolina, Chapel Hill. Shout out to Dr. Sturm, who I think is coming to us from there right now. But this is a census-based measure of health literacy, which is very useful for maybe some hypothesis generation, preliminary understanding of your area or the populations that you're hoping to study in terms of baseline health literacy. The downside is it's census-based. So it's going to be based on the most recent update from the most recent census data. That could be more than a decade old, and I believe is. I think the most recent update is from like 2010. I know this is 2009, but I think they updated their census data back in 2010. And the way it works is you look up a patient's address. It gives you, a quartile for their health literacy. And so you can kind of stratify your patients. Are they in the higher quartiles or the lower quartiles for baseline health literacy? Um, but it doesn't give you a lot of information about what the patient might need in a conversation, right? And so there are measures that do that. One is called the newest vital sign. This one is fascinating to me. I have not yet used it in studies because it requires a patient to look at a nutrition label for a pint of ice cream and interpret the data. And then they get scored on their literacy based on how they interpret the health information. I thought Dr. Peniston would enjoy this one. Yes, I see smiling. So it's really cool, but it's hard for me I haven't figured out a way to systematically put a high resolution PDF of the ice cream label in REDCap, so I haven't used it personally in studies yet. And the scoring can be a little bit challenging too. Um, what's another one? This one was developed at Northwestern. It's probably one of the more commonly used measures because it's very to the point, very succinct, and it's valid. The downside is it's not as nuanced, right? We're kind of asking the patient to reflect. And I would argue that the questions themselves are not the easiest to interpret, right? How often do you have problems learning about your medical condition because of difficulty understanding written information? Well, if you don't understand written information, how are you going to understand this question, right? So I think that there are limitations to prospective qualitative measurements, but they're a little bit more detailed than census-based measures. And there are many other measures that I didn't include here, but these are two of the most commonly used measures out there in the ethos. Um, All right. So, what is e-health literacy, right? This was a new concept to me, developing a web application. And it's very complex, but it's essentially the patient's ability to appraise health information from electronic sources. So, they have to get the information and then apply their knowledge as they, navigate an electronic resource to find answers to address their problems and then use the information to address their problems. That's a high level task, right? And so it's not the same as health literacy. It's actually a little bit more complex. And we're finding that the two do not correlate when they're studied simultaneously. You will see that represented in our data as well. I've done a lot of learning in this space in the last 6 months. So that's been really interesting. Okay, so you can see that e-health literacy encompasses health literacy, but also there's some level of like traditional literacy and numeracy, ability to use a computer, navigate media, understand scientific terms, or interpret any information. All of that feeds into e-health literacy. So it needs its own measures, right? And the e-heals is probably the most commonly used measure for this. It's a pretty brief form. It's about 10 questions. The first three are still considered test questions. They weren't included in the initial validation studies. But I do like this measure because I think that the questions are a bit more simple to interpret. And if someone was reading them to you, you could understand them a little bit more easily. And it asks very utilitarian questions that it rates in a very systematic way. So I think the respondent burden's a little bit lower. So I do like it. So we have been using this. Okay. And then digital literacy. This is the confident and critical use of a range of digital technologies for information and communication, and then like problem solving, right? So you have a problem and you want to be able to use some kind of digital tool, whether it's, a website or an application or a module to answer your question and solve the problem, right? And so there are ways to do real-time assessments of your digital literacy. I had fun doing this. It turns out that I was not able to pass for a navigation of a web health informed web tool because the bar for passing was more than 95%. I think I got like 93 or 94. It was hard. It wanted me to go through this application and complete some tasks. Anyways, it was really interesting. And they actually have several tools for looking at digital literacy in multiple media forms. So if you ever have a minute and you're interested, I highly recommend you check out this site. So how does this impact, how we develop interventions in for patients? in any kind of trial, right? How we phrase questions during consent or assessment, how we select follow-up needs and even strategies to prevent patient attrition, resource formatting and selection for our clinical use, and designing our tools, right? They have to be easy to navigate. As I said, I failed the digital assessment. And I would probably be considered somewhat educated by a lot of these health literacy tools, or a high expectation of health literacy, and I still struggled. So I think this can't be understated. So I think it's worthwhile to pause here and just think a little bit about some examples for how health literacy can influence our outcomes when we treat chronic diseases. And I picked examples from pediatric urology because I enjoy thinking about that, but you can find lots of examples from other aspects of urology too. And so this was a really great article. I'm happy to send it to anybody who's interested. They actually built a kind of conceptual framework for where health literacy comes into play in clinical settings. And so you can see that it has, these bigger areas, spheres of influence in terms of how patients access and use the health system, how they interact with their physicians. And this one, which I find super fascinating, the idea of self-care and self-efficacy, right? Because I would argue that might be one of the more important areas for us to modify. And I wonder if the arrow actually belongs here, kind of going up from self-care to both of these things. Are these part of self-care? Just food for thought. So looking at some examples in terms of impacts on access and utilization of healthcare, this was a great study produced by a good friend of mine from Children's Hospital of Atlanta, and he looked at testis torsion outcomes, in the greater Atlanta area. It had a pretty good catchment area to some very rural populations, around Atlanta, even extending up to Tennessee. And I think they had about 900 patients in this study, and they found that patients with substandard health literacy from that census-based measure that we looked at the beginning of these slides were more likely to end up with orchiectomy, meaning they failed to come in time for us to save the testicle if they were less health literate. Is this an example of poor access to care, or is it an example of poor self-care, right? Or lack of trust in patient-provider interactions? We don't know because this was a census-based study, right? But it's an interesting question. And it makes you think about what we could modify to prevent, patients losing organs because they don't know better, right? Because that's what happened here. Okay, so patient-provider interactions, another fascinating study. And I was laughing because these studies were written by the institutions that my partners trained at. So I feel like this PowerPoint really encompasses our group. But this came out of Seattle Children's, and Julie Chang is really an innovator in this area. She realized that they were getting a lot of patient phone calls for questions that she was sure they had talked to patients about these issues before in their preoperative counseling. Things about how to take care of incisions and wounds and catheters after hypospadias or hernia surgery. And so she sat down with all 11 faculty at Seattle Children's, and she interviewed them and, made them commit to a set series of counseling guidance for what to expect before, during, and after surgery. And she turned it into a video. And so she asked the question, okay, I've made these videos. Let me have some patients get the standard clinic counseling with a handout. Let me randomize some of these patients to video. So I think they had something around 200 something patients in the video arm and around 100 patients in the basic counseling arm. And then they looked at how many times did they come to the ER? How many times did they have phone calls? How many of them had surgical complications? And she didn't see a statistically significant difference between the two groups for surgical complications or overall, health utilization as a whole. But when she looked closer at phone calls and ED visits, there was a decrease. So I think there's something here. Is the delivery perfect to decrease healthcare utilization? Maybe not. Maybe a different kind of resources needed. But it's a start, right? She's changing how we communicate with patients. Okay, great. So another very interesting thing to think about. And we'll talk a little bit soon about how it could impact how you design studies and maybe even the informed consent process, because I find that very fascinating. Okay. And now getting into, as we've talked about, I know I keep harping on this, but I find it fascinating, self-care, right? How do patients answer questions for themselves, care for themselves? What do they rely on, and how do they solve problems, right? These are the questions that we want to be thinking about here. And then, are there some extrinsic factors? What support technologies are there out there? Because this is something we can modify, right? We can't modify mass media. We could potentially help with health education and resources and support technologies. So you'll see that reflected here. So this was a study out of Nationwide Children's, where one of my other partners had trained, and it was a great question. They designed a very simple survey, and they asked patients, did you tell your kid they had surgery? Did you tell them about it? Because a lot of our parents never tell their children that they had surgery on their genitalia in infancy. I see the shocked faces. I share your shock, right? And so why would someone do that? Because it's stigmatized and they don't know how to have the conversation. And this is an example of like how we, aren't helping patients develop any knowledge to provide self-care. If they don't know they had a surgery, they certainly can't be expected to take care of it. Right. And so they got some really interesting information. I think about 80% of patients had either told their child or were planning to tell their child at a specific time frame. If they had lower baseline health literacy levels, they were less likely to be telling their child about the surgery, maybe dropped to about 70%, or planning to tell them later, maybe because they felt more confident explaining it to an older child with more life experience, right? But yeah, I don't think he'll have the development to understand ever. I mean, I would hope that right. It would be possible. And not important to his development. Well, that's a health literacy modifiable concern here, right? I don't think it will affect or he'll remember it. Again, that is not their call, right? This is their child's body. They should know that this is something to disclose. Only if he asked about the scar and to wonder where it came from. I mean, these quotes really hit me. I was just, floored by this information. Somewhat reassured that most parents had a plan to disclose or had already disclosed, but I think the reasons for not were they're worth thinking about. Um, Okay, so we can see how, if we don't provide that knowledge to patients, they can't enact self-care. They may not know to access health resources. This can absolutely have a trickle effect on health outcomes, right? And it can affect our studies. The quality of our studies can be affected, right? If patients don't understand what we're doing and why we're doing it, we may not be getting the results that we want to be getting, right? And so I think this has major implications for clinical trial design. Okay. And then finally, kind of going into the health outcomes piece, what happens here? This is probably some of the most exciting data from our collaboration with IU because it gives us something to act on. So we looked at several aspects of hypospadias care and we said, okay, we have 600 patients. We'll see which ones had, the most basic kind of hypospadias repair, a distal hypospadia, single stage. How many of them came back to clinic, right? We asked a really simple question. How many came back to clinic at all or within 3 months of the recommended time frame? And unfortunately, and this has been shown by other authors too, 40% of our patients were lost to follow-up, right? And a large chunk of our lost to follow-ups were patients who were economically deprived. The census-based measures didn't pan out statistically, but you have to wonder, did they not come back because they didn't know better, right? Because these are usually intrinsically tied. And so how are we going to get good study data on hypospadias patients if almost half our patients aren't showing up to clinic? We aren't, right? We are not getting the whole picture of what's happening after these surgeries. Can we just chalk it up to how excellent we are? I don't think so. Long-term hypospadias outcomes suggest that 15 to 20% of patients with the simplest hypospadias have issues. And when they look at psychosexual factors, that rate of complication goes up to closer to 50% in studies of adolescents. So I think we're missing a large piece of the puzzle, at least in hypospadias and possibly other disease states where we have similar issues with loss to follow-up, right? So this is a modifiable, risk factor for problems with good clinical research and problems with clinical outcomes. And it's worth thinking about at the time you design your study, right? Any patient-facing study. Okay, so how can we improve how we design studies and care paradigms for common conditions? Well, it might be helpful, and this is where I think that census-based measure, for health literacy can help you plan the study. You could just get a sense of the baseline health literacy of the population you're hoping to study, right? You could just say, what is the expected literacy of the population I'm going to be talking to? Because maybe I need to adjust my resources to reflect the expected reading level, right? Maybe a lower reading level, third grade or below, or focus more on video-based or audio-based explanations, right? Change how we deliver information, kind of goes to what I just said. Increase our patients' trust in care and good information. How do we do that? Well, we have to make sure we're giving them information they can understand and repeat back to us, and they can find reputable resources that we should try to figure out how to provide, right? Format the resources in ways that they can understand it. And ultimately, our goal with all of these things is to improve patient self-efficacy, because that's the core of everything we do in patient-facing research and clinical care, right? Okay. So there are some really cool models in family medicine because they're a lot nicer than urologists are, and they spend time talking to patients. So they thought about this. So they came up with this really cute acronym, which is called EDUCATE. So for changing how we deliver information, our focus is on enhancing comprehension and retention. There are interview techniques that you can actually practice that are provided in this article. I'm happy to share them with anybody. I tried listening to them and started using them in practice a little bit more, and I do think they're helpful. Deliver the information in a patient-centered way, right? So if we're talking about numbers, or statistics, maybe contextualizing it for the patient and making sure that they understand what those numbers mean to them, right? Meeting the learner where they are. This is where I think, there is a social determinants of health screening tool in Epic for those of us who have access to Epic that is done by most patients who come to primary care visits. I wonder if it's something that we should ask for before even study visits, because then you might know what kind of explanation they're going to be able to understand or appreciate. And obviously, communicating clearly, addressing health literacy, and setting goals, right? Maybe tell them what you're going to explain to them, say it to them, and then have them say it back to you. That's kind of what they suggest in this article. It's a lot of work, and it does affect the informed consent process, which we'll get to here. Just, in 1 second, I froze. Sorry. This was really cool. There are, from the National Academies of Sciences, there are these resources on increasing our trustworthiness, which I thought kind of tied into good communication. But, the idea that you're fair and accurate and obviously honest and confidential, very important when we're dealing with genitalia-based diseases where there's a lot of stigma, right? And then being just authentic and reliable and devoted to them. But there are some, resources here for how we improve accessibility of the things that we provide to our patients, and also how we interview patients. So there's this Health Literacy Online Center that has some really cool modules to help us with that. Okay. So this is a crazy study. I had to share it here because I think anybody who does research and is involved in informed consent should know this. So, health literacy and informed consent materials. I think the title says it all. Designed for documentation, but not comprehension of health research. They took this scoring card, which is called the Revised Salmon Cat. I apologize. I can't remember what those stand for. There were these two measures that looked at, overall accessibility and readability, and then interpretability at multiple reading levels, and then reading comprehension. And so they took about 100 different types of consent forms, and they looked at these consent forms across multiple fields, and 97% of them required a high level of health literacy to even interpret. So this process has not been designed for patients. And so I think we often feel that we're like covering our bases by saying we're doing something for informed consent. But my question is it informed, or is it a piece of paper that the patient signs, right? Probably not as informed as we think it is. So I think that the future of improving our research and improving the real-time effects and improvements to patient care from our research is going to be centered on responding to these concerns, right? And how do we do that? We ask the patients. We ask them what they want. We get their perspectives early and often in the design of research questions. I think, Dr. Peniston and Dr. Ellison have done great work with the CAIRIBU Consortium on early, often, and frequent, patient engagement. I can't overemphasize how important that is. It actually is critical to everything we're doing. And what parts should they be involved in? The design of the research, right? Like, we want to do an intervention. It's not just the questions, right? They can help us identify high priority questions from a patient perspective, which is important. But we can ask them, is this intervention something you would even do, right? Is it something you would do? And is what we're asking reasonable and feasible from your perspective? And if the answer is no, it's time to go back to the drawing board, because if patients can't do it, we aren't going to move the needle in any kind of real time, right? We're going to make a lot of errors. We're going to be frustrated by attrition, and then we're going to, apply for more grant funding, which in this day and age is just, a really interesting process, as we were just talking about before this started. So I think that, we were fortunate to have the advice of Dr. Peniston early, but I don't think I understood why this was so important until, I spent a little more time thinking about health literacy in this fellowship. So okay, so what did we do here? We asked patients and parents of patients who are young and physicians. You have hypospadias, or you treat people with hypospadias. What would help you take better care of yourself? What would help? Just tell me what would help you, right? And we gave some options, but then we gave a lot of space for free comment, right? Because this was hypothesis generating. We had no idea where to start. And we found that most people wanted something app-based. They wanted to save their views. As teenagers, no shock here, they wanted some privacy, right? They wanted some interactive activities or some kind of, video-based information, non-written information for reference. They wanted to know what other patients were feeling. And they wanted to be able to fill out, symptoms for quality of life. And interestingly, young patients, and I think I cut off the column for 16 to 20-year-olds, but young patients wanted their parents to do it for them, right? They didn't want to do it themselves. And I said, that's fair, right? But the parents wanted to be able to, ask questions for their appointments, get a guide for disclosing things to others, or know what questions to ask at each of their appointments. And then we asked, like, how often would you use the tool? And unfortunately, I put our insignia over this, but most of them said frequently. So yes. So the answer was most people would use the tool frequently. Little children said, I wouldn't, but my parents sure would. And I said, that's very reasonable. I don't think if I was 5, I'd be excited about using an app. But that's what made, qualitative interviews of 5-year-olds really fun. Okay. So what did we find out? Well, we built that app. We responded to them, and we asked the question, okay, so we built this app with everything you asked for in it. And let's see what you're coming to us with in terms of literacy and baseline knowledge. And I think we've interviewed 6 or 7 patients. These were just some sample quotes that I thought were interesting. So we looked at their baseline health literacy using the brief score, right? That was that 4-item valid qualitative score for health literacy. And everybody so far in our entire study has measured as adequate. But e-health literacy, interestingly, has been a little bit more variable, right? We've had a few patients who had, what we would consider low health literacy scores, and the rest had high. And that did seem to translate to, the rate of having any errors with completion of tasks within our app, because we're testing app task navigation. And we also, are doing some cognitive interviewing about how much sense do the questions make? Do you understand what the question's asking? Does it mean anything to you? Does it seem important to somebody with hypospadias? We're still asking these questions, even though we used a Delphi that I presented last year to develop the questions. We are still getting information about how useful these questions are to people with hypospadias. And interestingly, every single patient has had problems with information retrieval. So that doesn't seem to correlate with our brief score at all. And this is why I brought up earlier, that brief measure may not be the best measure for true health literacy, because we are finding also similar issues with comprehension, some really interesting data that we're getting from our cognitive interviews. For that. So our focus is an iterative revision of the app contents to improve information and retrieval and comprehension. We want to give the patient strong clinical context for when to make those decisions, right? We found that a lot of these were because patients were trying to recall their entire life of hypospadia surgeries. We only wanted their most recent experience within the past 3 months, so we changed the context. That seemed to help with the information retrieval piece. We found that the interface had buttons that looked for the same function that looked a little different between tabs. That made it hard to navigate, led to more errors. We changed that, right? So we've provided a resource that's vetted by experts. We are revising pieces of the resource to reflect comprehension and information retrieval. And we are making sure that it's easily navigable, right? And so our measures of usability have been very high. I'm super excited about this. We had patients do it with us initially, but at 3 months, their scores actually went up for system usability. So they found it easier and easier to use each time they interacted with the interface, which to me is a litmus test for hopefully something that will be sustainable. Thinking from a dissemination standpoint, there's like the maintenance phase of the re-aim framework for dissemination of interventions. We want something that they can complete annually, send us a report, and maintain their work within the application. What our app does, and I don't know how much time I have. Do I have 5 minutes to show it, Alex? It's kind of fun.
Definitely.
Okay. I tried to take more screenshots, and I was like, this is like 800 screenshots. I think it might just be easier to like pull it up. Okay. So long story short, we're using this information in real time to improve patient self-efficacy, which I think is hopefully going to influence access of care and health outcomes, right? That's the hope. Kind of drawing back on our previous examples. I think health literacy actually is a vital sign, and we can, measure our patients where they are and hopefully improve our outcomes, but also research, study design, dissemination, and intervention. And we need to broaden our horizons to non-written resources. I can't tell you. I find it very troublesome to know that I've had patients ask to see me for their hypospadias because they heard about me on Facebook. I'm like, I have all these papers. You're learning about me from Facebook? Like that's how the referrals are coming, but that's what people use, so we have to diversify how we disseminate high quality scientific information, because health literacy is evolving and how people inform themselves is also evolving. And so our future interventions hopefully can take patient perspectives into consideration throughout the design of our studies and the design of our interventions, to improve the time till dissemination of intervention. In NOLA, there was a scientist from the NIH who's like a total innovator in dissemination intervention science, who said that the average time from ideation to matriculation of a scientific idea in clinical practice is 17 years. Insane, right? Why is that happening? I think this is part of it, right? I think we are missing the mark in our study design, and we can actually design more efficient, more cost-effective trials by thinking about this early and often. Okay, so I'm going to show the app and take any questions because it's more fun to think about. This is my lab. They're amazing. All of them are amazing. I'm sorry, I was going to add Paisley Joe's photo to the page, Haley, but I know sometimes we don't want to share our children's faces on social media. Um, but these are our wonderful user-centered design folks, Laura Grady, Diana Gutierrez-Meza, and Ezra Alagaz are our qualitative team. Garrett Smith is our app developer. Haley is my lead research coordinator and basically my lifeline. And Caitlin is a medical student who's been working hard on the health literacy aspect of our data analysis. I have an outstanding mentor team that honestly, I know I'm supposed to graduate from needing you theoretically next June, but I don't think I'll ever be ready to graduate from needing you. So thank you for all that you do. And to my amazing trainees who just make me so proud and collaborators, I just wanted to say thanks to all of them. These are my references. Happy to share all of them with anybody who's interested. And that's my oldest son, being an innovator. Okay, great. I will pull up the app and take any questions. So I contextualize it like that. And I have found, I had one patient say to me in the clinic the other day, what was it? That was surprisingly helpful. And I wanted to say thank you for the backhanded compliment. But I think that it was a breakthrough. The idea is that, you know, maybe as much as social media gives me the ick and I don't understand it, it's time to get over that because
Yeah.
that's where people are getting their information. Can we create a vetted or kind of tagged resource that says this is a high quality health information data center, right?
Hmm.
And the UK did a great job making, scientific journals publicly accessible, right? At the NHS provides everybody access to those articles. But could we in the US be kind of spicy and create, a TikTok library of great scientific
Yeah.
resources with links? People will click. You know what I mean?
Yes. Yeah.
Especially apparently if we look cute or act really weird while we present it. And I think both are possible. Probably all are possible. But it's time to diversify how we communicate with the public because we are losing public trust and public interest with what we're doing right now. What we're doing now is not working. So, time to get a little weird and a little creative and put ourselves out there.
Yeah. No, I agree. I totally agree. And I'm watching the chat here, and if anyone please unmute and then feel free to show us the app too. This is really cool.
Okay, this is my baby. It's so weird to see it in real life. I don't even know how to describe it. Like a decade in the making. But patients, they log in, they create their profile. The questions change based on what they
Mm.
put here. So if they're 5 to 10 or 11 to, you know what I mean? So we have age-adjusted questionnaires. We ask them some basic things about their surgeries. I'm actually hoping to look at this later because I think if they can't tell us how many surgeries they had or what they had, another modifiable thing to work on in the education space, right? So everything is, you know, uh, research generating this application. But they can develop a care guide. So this is the WISH questionnaire. This was developed over the course of about a year with a Delphi panel. And so patients come in and they mark, like I never have these issues, but sometimes experience some of these. And we cover, 6 domains of health-related quality of life that we identified from our previous qualitative work. And they come here and they generate a care guide. This is the coolest part. I love this. Okay, so it's this super succinct little table, and they can download it and send to their physician by my chart. Hey, I need to see you in 3 months for these couple issues I'm having. Well, the urologist could come and say, okay, that's great. There's absolutely no clinical information in there. So could I get more? And the answer is yes. There's a question guide based on the specialty that we are referring them to. So if they had any psych issues or issues for endocrine or issues for sexual health, those would populate here. But they can send an itemized question guide of the things that they flagged when they were filling out the form to their clinical care team. This is where I am trying to improve doctor-patient communication. We're going to be assessing that in our upcoming efficacy trial if I can find funding for it. And then we have an index of regional experts. So say that this care guide said, you need to see a psychologist. Well, who do I see, right? They could go to the regional experts and they could actually find a psychologist. They can find a sexual health counselor. these are, I want to change this picture. I was post-call and really greasy. It really bothers me looking at it, but it's fine. So yeah. So anyways, they can look up regional experts, and then they can go to a section called What I Wish I Knew. So they can get, these are explanations that were crafted by a panel of 290 pediatric urologists who gave us advice on information that they thought was important to include. These are black and white drawings because patients said they didn't want color drawings. They found that stressful to look at. I thought that was kind of interesting because I would never have thought about that. Um, this is the most exciting part here. We partnered with a patient advocate who, was treated for hypospadias, but is a clinical social worker, and he has a podcast. He's got an amazing voice, great dictation style. He recorded content for us about like a real life patient experience about like voiding and stuff like that. So patients wanted some like audio content, some visual content, some written content. It's just so cool. And we're just really grateful to him for creating that for us. Because sometimes these things are things you can't type. How should my penis look? What do I type about that, you know? Um,
Yeah. Yeah.
so yeah, but needing more surgeries, having kids, psychological well-being. Yeah. So it's really exciting. Kind of a dream to be able to at least try to do something a little different. And my hope is to see that this tool, at least in our preliminary effectiveness trials, prevents loss to follow-up and improves patient perspectives of doctor-patient communication because they can actually send us the questions that they have from the measure. And then we usually know how to address those. The success rate of treatments for most of the functional issues of hypospadias are like 95%. So if we can just get them into the clinic, we can fix stuff. Um, so that's the cool part. So that's where we are. But yeah, learning a lot from all our patients.